Good afternoon and welcome to ASM Microbe Online. My name is Robin Patel and I'm the president of the American Society for Microbiology. Even though I'm disappointed that we're not able to be together at ASM Microbe in Chicago, I'm glad to have the opportunity to connect digitally. ASM has worked hard to make sure that the ASM Microbe online experience is an excellent one for all, a summer of science where you can access dynamic, cutting-edge research that you expected at ASM Microbe 2020 from the safety of your home or work. New and breaking scientific content from the ASM Microbe 2020 program will be accessible online throughout June, July, and August. Starting today, you will be able to explore abstracts accepted for ASM Microbe 2020 in the format of e-posters. Presenters will be adding e-posters through July, so check back frequently to view the science of your peers. E-posters will be open access to all individuals, regardless of their ASM membership standing. Throughout the summer, ASM members will have access to leading experts on the hottest topics in the field, including COVID-19, antimicrobial resistance, and global public health. Following live and on-demand viewing, live after chats will be available for select sessions, allowing participants the opportunity to engage with speakers and experts. ASM has been working to ensure that we provide an online format that makes the content easily accessible and affordable, attracting not just those who plan to attend, but also those who might otherwise not have been able to attend the in-person event. We want to make sure that we're meeting the needs of all microbial scientists, and especially those of our students and early career scientists. We want the future leaders of the field to not miss an opportunity to advance their career, share their scientific findings, and be able to network digitally. Our hope is that trainees, early career scientists, and technologists will gain new connections and find colleagues for future collaborations. I want to extend a special thank you to the members of the ASM Microbe Program Committee for their commitment to delivering the scientific content in a digital format. The July schedule of sessions will be available on the website later this month. Please visit the ASM Microbe online page for more information on future programs. Now, without any further delay, let's get started. I would like to welcome ASM CEO, Dr. Stefano Bertuzzi, who will kick us off today with his talk titled, Science in a Post-Pandemic World. Stefano?
Thank you, Robin, and good day, everyone. Delighted to be here at the kickoff of the first virtual ASM Microbe meeting. And I would like to start by sharing with you the overview of the COVID-19 pandemic strategy that ASM put in place. What a year this has been for all of us, including ASM. Imagine running an organization like ASM with all the management crisis, canceling meetings, micro meeting among those, and all the other meetings that ASM had planned. Switching all workers at ASM to remote working, postponing a super exciting grand challenge that we had, but after all, we found ourselves with a grand challenge on the fly to take care of, so we didn't have to look any further, minimizing the financial risk for the organization. As if this was not enough, the pandemic strategy, the COVID-19 pandemic posed ASM a challenge right square on its mission. So we couldn't hunker down and take care just about regular management, but we have to actually ramp up. We had to actually do more in order to fulfill our mission, in order to serve our member, to make an impact in the whole world. And to do that, we put together what I think was a very robust strategy for COVID-19 response. And we did this by taking a very collegial, integrated approach across functional areas, not working in silos, but also across various departments at ASM and integrating the world that staff and volunteers had. Staff developed a comprehensive strategy for tackling the COVID-19 pandemic, and put the volunteer and subject matter experts on the front line who've been the spokespersons for the organization. And I think that through this, ASM helped move the needle and make an impact. First of all, by understanding and serving the needs of the clinical and public health microbiologists. And here, I would really like to give a virtual round of applause, but really extremely heartfelt to all the clinical and public health microbiologists of the country and of the world. They have done a phenomenal job and under very, very difficult conditions. And I want you to know that ASM was here from day one, helping you and really help serve your needs. ASM connected with the White House COVID task force to bring the voice and the problems of the clinical microbiologists to them so that action could be taken. And we worked very closely with Ambassador Birx and her team, who will be the next speaker, to whom we're very grateful. ASM also worked extremely closely with the federal agencies, in particular FDA, CDC, and the Department of Defense. With FDA in particular, trying to ease the regulatory burden that was creating problems during the pandemic. We also worked very collegially with Congress in helping inform, provide evidence base for the various activity, both on the appropriation and on the authorization that were going on. And ASM engaged, last but not least, with the public. Very important to provide evidence-based and real communication to the whole world. And ASM counted over 7,500 media appearances in this front. Of all the many, many activities that ASM took on during the COVID-19 pandemic strategy, in case you haven't noticed, we're all exhausted, I'd like to point out one of those, which is the COVID-19 registry. And to this, I would like to give a big thank you to Dr. Lynn Enquist, past president of ASM, Dr. Harold Varmus, who's been our chief consultant, Dr. Roz Sandry Golden, our editor-in-chief of the Journal of Virology, and to board member Von Cooper. What we did with them and many other curators is to assemble at thunderbolt speed a resource for the whole world that aggregates the most significant resources in science, COVID-19 and SARS-CoV-2. Think that every year the team screens over 2,500 research articles that come through and selects a very small number of these to be featured on this site, which has reached by now over 26,000 unique users. I am extremely pleased that when I travel the world, travel the world virtually these days, I hear so many people saying that the first thing they do in the morning is actually to listen, to tune in on the registry to be able to get updated on what has happened in science in that space during the day. And this brings me to the core of the message that I want to leave with you today. So in leadership, just like in science, one of the most important skills is that of being able to recognize patterns and trends, which give us the ability to sort through complexity, to find perhaps those truths that we can recognize from other situations. This understanding may be helpful to solving complex problems. Differently from the Darwinian evolution, Stephen Jay Gould's punctated equilibrium approach complements that, suggesting that evolution occurs as a series of bursts of evolutionary changes. These bursts of change often occur in response to environmental triggers and are separated by periods of evolutionary change. In the next few minutes, I would like to offer the perspective that the COVID-19 pandemic is one of those disruptive events that can lead to new speciation, meaning that its impact on science, on education, on business, and on society at large is going to be so significant that our space as a professional society, as a field of microbial sciences and science in general, will be significantly different in the post-COVID era. And this approach was also spoken about, not so much on the science side, but on the world order, by a very illuminating commentary in the Wall Street Journal by Henry Kissinger, making the case that the coronavirus pandemic will alter forever the world order. So what I would like to do is take the lens of science and what ASM can do to think of what we could be called to do and what we should do in the post-COVID world. I was mentioning about solving to complexity and thinking about punctated equilibrium that allows changes and something to go away and something new to come, a new speciation. And I think that World War II was certainly one of those events. And here, let me go back to Franklin Delano Roosevelt, who at the end of World War II, when the world was in shambles after this devastating war, and the US came out of this and the Allies as the clear winners in this world. And he reflected at the end of the world and was really struck by something. He said, the toll in lives lost during World War II was actually only a fraction of what just two diseases are bringing to the world, into the country every year. And so he tapped his science advisor, Vannevar Bush, who was the first science advisor to a US president in history, and told him, go and think about what could we do to really rethink all the great amount of technology and innovation that was injected into the system during World War II. Talk to the general at the Pentagon and see what this can be declassified and what this can be put to fruition to the whole world. And he uses a beautiful sentence that honestly gives me the goosebump every time I think about it. And he said, we're not doing this because we won the war, but because we owe this to future generations. And that is exactly the point. Science is about the future. It's about hope. It's about the future generation. And so Vannevar Bush went to work exactly 75 years ago, almost to the day. And on July 1945, he published the short report, Science, the Endless Frontier, that many of you may have read. And in essence, to summarize, from my perspective, he actually said two things. He said, science won World War II. Now we're going to use science to win the peace. And this report was so effective that it laid the foundation for the US research system as we know it still today. The partnership between the federal government and the university started thanks to Science, the Endless Frontier report. Before, there was no such a system. The National Science Foundation as an agency funding basic research was started through the Science Endless Frontier vision. And the indirect cost system allowing the university to be funded based on the excellence in science and envy of the world in many respects is due to this. So now let me think there's issues that were brought by the Science, the Endless Frontier, and pick the four main topics that were present in this report. And let's imagine how they could be after the COVID-19 crisis and what could ASM contribute to. So we'll see what was in the Vannevar Bush report, what the world could look like with respect to those points after COVID-19, and what this means for ASM. So the first thing, as I already mentioned, Vannevar Bush said the diffusion of knowledge that served the military so well to win the war will now need to be put to work to win the peace. And this will create new enterprises and new jobs. So I think that in the post-COVID world, what this will mean and what we need to work toward is really a world of science, open science, open data, open access to publications. We don't think that government mandate is the way to do it, but we need to get there through sustainable model. And very important is that of the integration of disciplines and of scientific societies. Very often our constructs reflect the science of 75 or 100 years ago. And science changes so quickly that we will need to see how the interdisciplinarity needs to come together and what are the best constructs for serving science and society based on what we will encounter in the next few years. ASM is already on this path. This is something that we have already started. The open access path is something that we have married, and we want to go in this direction. We are working very hard to develop new business model that can be sustainable, and we're exploring, and we have a path for doing that. And also, I think we need to look at the collaboration, consolidation, and integration with other societies in the best way to serve the science of the future. Also, the Vannevar Bush vision was calling for a health agency, a national agency. I think that in the post-COVID world, we'll need to expand this to a global vision. Science is global, and global health now is something that many people understand. Of course, microbiologists always knew that microbes know no borders, but what a better situation to build on for global science than the situation that we're in right now, where we have the whole public understanding this. So I think our job is carved out here. We need to rethink ASM as truly a global society. We need a big plan. And I think that the time is right, but we're going to have to deal with some headwinds in this. I have spoken last year at the President Forum at the Microbe meeting in 2019 about the impact of globalization on science. And here you see the reference where you can look at this talk. And since then, I think it's still valid. Those concepts are still valid. But if anything, they have become even more problematic at this moment. You see this cover of The Economy from last month, emphasizing how globalization may be in peril, and country may think of themselves as self-sufficient. So we need to work very hard in this direction to build a global health and global vision. And ASM has a big role to play as one of the largest associations in science. I mentioned the role that the Vannevar Bush vision had for government to support research and the partnership between government and university. I think in the post-COVID world, we really need to expand this, and we really need to think more and more as science and scientists as part of societies. We don't need ivory towers for sciences. We need to be very aware that our job as scientists is that of working for the public, working for the people. And we have the big responsibility of answer the societal needs. In the moment of COVID, it became very apparent that the role of science was so fundamental. And we really need to build on this in answering the societal needs through science. This is a big job. And I think that we need to do this. At ASM, we have been working hard on this already by ramping up our science policy and advocacy program in the past few years. And our vision of science for solving humanity's problems as just opposed to publishing the next paper, which is fundamental, but is fundamental in order to serve those needs. This is whether through the essential basic science, which is the foundation of every result that we will get, translational and applied science. We really need to think about impact that can be seen and can be felt. ASM advocacy needs to really be very strong and outward face for impact in the world. In this case, I always think of what Abraham Lincoln said, saying that policy without the sentiment of the people is worth nothing, but policy with the sentiment of the people is worth everything. And that is why, as scientists, we need to engage with society, and we have this big responsibility. This is the approach that we want to take at ASM. Finally, Vannevar Bush recognized the important role of investing in workforce in science, and he speaks in particular about youth and the young generation and scientists. I think, based on what I just said a minute ago, that we need to rethink and expand this concept of Vannevar Bush to a diverse workforce, a workforce that reflects the composition of society. Again, if the workforce in science doesn't look like how society looks, how can we have the trust? How can we have that relationship and not be perceived as an elite? And so this is very important to make sure that we develop in science a culture of inclusiveness and diversity in a very deliberate way. ASM, we've been doing this, and this is not just in reaction to the latest events, but for the past 2 years, we've been on a journey on this path. 2 years ago, I had asked the board of directors to start a path of elevating diversity within the society in order to make an impact of the microbial sciences that we want to become the most diverse and welcoming field possible. We had and then we have established a DEI, a diversity, equity, and inclusion task force that is working very hard to envision how we can give the diversity and inclusion the most prominent space possible in the society and in the microbial sciences. So stay tuned, because there will be big actions in this direction. So with this in mind, I think we have a roadmap emerging. I think we have opportunities as ASM to be change agents for the science and for the world. And as scientists, I'll say it again, we are here to serve the needs of society at large. I think these are challenging times for science with the anti-vaxxers and the attacks on science, and we'll hear about this from Dr. Peter Hotez soon. And I think it's also a challenging time for society as an association. We had to reinvent the meeting. How is publishing under the open model? Something, as I said, we embrace, but we need to develop in a sustainable way. What is the value of being a member to all these problems? And certainly, we want to be laser sharp focused on our mission, and we want to be in overdrive on our mission to make a real impact, because the opportunities that we have in front of us are truly unprecedented. ASM started this journey in 2015 when the Futures Group envisioned a new strategic plan for ASM. And what you hear today is the natural evolution of that. So we are here to harness the power of our members, of all our stakeholders and professional staff to shape this future together. This is our responsibility. And so let me close on this note with one of my favorite philosophers of science I find particularly inspiring in this context. Optimism, beauty. The future is open. It is not predetermined, and no one can predict it except by chance. We all contribute to it by what we do, and we are all equally responsible for its success. And this is from Karl Popper, and I think this is a perfect beacon for us to help build the future after the COVID-19 crisis for a scientific endeavor that really serves society and humanity. Thank you very much. Now it is my distinct privilege to introduce to you Ambassador Deborah Birx, who is currently the White House Coronavirus Response Coordinator. ASM interacted regularly with her and her team in this role, and I would like to thank her for her service, for her leadership in this very complex position. during this challenging situation for the country. We believe that the country would be worse off without your leadership, Ambassador Birx. So a very heartfelt thank you from all the microbiologists of the world for all that you do. Dr. Birx received a medical training as an immunologist, a fellowship in Dr. Tony Fauci's laboratory. Dr. Fauci will also be speaking at the ASM Microbe online later in the summer. Dr. Birx has a deep experience in vaccine development. She worked on developing HIV vaccine, culminating with the Thai HIV vaccine efficacy study, the first trial supporting evidence of any vaccine being effective in lowering the risk of contracting HIV. And I believe it's still the only HIV vaccine study to show efficacy as of today. Dr. Birx is an HIV/AIDS researcher and advocate. Dr. Birx was instrumental in getting the Department of Defense engaged in PEPFAR in Africa in 2004 and on. And we also recognize Dr. Birx for her indefatigable work in PEPFAR at Walter Reed Army Institute of Research, at CDC, and since January 2015 at the Department of State, where she serves as a coordinator of the United States government activities about HIV/AIDS and is the U.S. Special Representative for Global Health Diplomacy. Finally, let me conclude by recognizing Ambassador Birx's role and mentorship in inspiring a generation of women in science and medicine by being such a credible and effective role model. So, Ambassador Birx, it is our privilege, it is our honor to have you open the online ASM Microbe Conference and to your presentation. Thank you very much.
Thank you, Stefano, and really thank you to Robin for really opening this really important discussion just a few minutes ago. I just want to start by thanking the Society. I know your work well. I've known it through decades. Critical at the beginning of PEPFAR. I know many of you know that PEPFAR has been responsible for setting up probably 90 to 100% of the laboratories in resource-limited settings all around the globe, all in a tiered capacity, from the smallest health post up through health centers to district hospitals to regional hospitals to reference labs, and really working with us to develop lab strategies for every single country around the globe, including quality improvement and quality assurance. All of that was done in partnership with ASM. So when I got the call, I was in sub-Saharan Africa at the moment, and got the call to come back and help with the COVID response. Upon arrival on 2 March and looking at the lab situation, it was really the administration's recognition that we had to not only involve the societies, but also our commercial sector, our research sector, to really expand COVID testing in the United States and around the globe. I see that you have some brilliant epidemiologists, so I'm not going to talk too long about the epidemiology of COVID, but just around the 2 things that I think were surprising that people aren't often talking about right now. But I think when we get through this and we look back historically, it will really provide some insight of what we didn't expect in all of our plans and our planning for a pandemic around the globe. Having worked in resource-limited settings for the last couple of decades, I think we all thought that an epidemic, particularly a respiratory epidemic, would hit resource-limited settings in a very difficult way. So when I was in sub-Saharan Africa, we were responding to avian flu potentials, we were responding to flu outbreaks, we were responding to H1N1 concerns, as well as the ongoing epidemics that we were dealing with HIV, TB, and malaria, and Ebola. And so I thought we all thought that this would be a significant problem in resource-limited settings. And then we had COVID. And if you follow the data around the globe, even though part of sub-Saharan Africa is in their winter, you can see that the impact of COVID in low-income countries and low-middle-income countries is far less than what we had predicted on paper of a respiratory epidemic. I think there's many reasons for this, and we'll follow the science and figure it out in time. But one thing is many of the low income settings have very young people. And I think this epidemic in general has been fairly sparing of significant disease in children, particularly children under 18, and in young adults. That's not to say that they don't get infected. They clearly get infected, but their severity of disease is a very different profile. And I think that is sparing some of our resource limited settings as far as having high hospitalizations and mortality. So when you look at the pandemic around the globe, you can see its largest impact for both mortality and cases that have been reported is in high income and upper middle income countries, from South Africa to Europe to Russia to the United States and now into South America. And as we look at this, it really points us to that we really have to not only plan pandemics, but learn from pandemics and really adjust our resources and our interventions based on this knowledge. I think the other thing that surprised me, and so one of them was the differential impact on countries by income level. The other one was the amount of asymptomatic spread. And so when I started tracking this very carefully, and you could see it start in Europe, to have that kind of explosive, almost from the beginning, logarithmic spread, is really tells me that there was a lot of cases that were there and not detected until it hit vulnerable populations. And that was differential in each of the countries, and certainly differential in the United States if you look by state by state. And so there's early warning signals, and this was this was what I hoped would happen, but you can never predict. There was amazing cooperation between my colleagues that I've known for decades in Europe, South America, and Africa throughout this epidemic. And I think just as you all are working together horizontally, I really want to acknowledge and applaud the information sharing that has gone on about both the epidemiology and the clinical outcomes and clinical care of our COVID patients. In the midst of their own pandemic in Europe, they were very open and sharing with me information that was critical for us in the United States of adjustment and clinical care, adjustment of clinical guidelines, and also new insights on what could be helpful as far as testing and testing modalities. And so I want to acknowledge the camaraderie that has existed since the beginning of this pandemic across countries and how helpful it has been to be able to get information from my European colleagues. And where we stand today is a very different understanding of COVID-19. And you all have been side by side with me in this. And I just want to, again, thank the American Society for Microbiologists and really the laboratory directors around the United States. We have asked you to bring online really 8 to 10 to 12 different COVID test assays. But it never was just about the testing and the assays. It was about all of those components, from the nasal swabs, the viral transport media, to the extraction media. That very early on, you pointed out where there were difficulties. And those difficulties that you alerted us to then resulted in the federal government engaging in what we call the Defense Production Act to really increase both swab production, the transport media production, the tubes required for the transport media, and finally the extraction media. And I think for those of us who have been working on an RNA virus for a long time, I just want to thank all of you around the world that helped build the HIV platforms, because it's those very platforms that are being utilized today to provide these tests around the globe. And so all that investment that we made a decade ago or 2 decades ago through PEPFAR is now being realized in COVID-19 testing. And I think that's really a real accomplishment in the work that you have done as a society to really work with laboratorians around the globe to increase capacity around the globe and increase technical abilities at all levels of the laboratories. And it was that strong work that is leading us now with these platforms available for testing. So I just really want to thank you for your investment in both human capacity and research capacity, because that is really paying off in dividends around the globe right now as we move COVID testing onto the HIV testing platforms. And it's really made a huge difference in access to tests. And so we have gone from about 1,000 tests a day to now over 500,000 tests a day in less than 3 months. But still, we need innovation in testing. And I think it's more than just more platforms and more tests. If you look around the globe, the way people are doing 1 million tests or 10 million tests is they're doing pooling. And so really asking the society and the researchers that are there listening to me. I never give a talk, if those of you who know me from that far, without asking for things. And so asking you to really look at this issue of platforms and pooling. Pooling would give us the capacity to go from 500,000 tests a day to potentially 5 million individuals tested per day by those poolings. As a country, we are way under 10% positive, although there are specific states that are above that. In fact, as a country, we are at about 6% test positive, really opening up the opportunity to doing 5 people pools or even greater. And I think the university structures in many of your laboratories that you're embedded in will really provide that opportunity for people to return to schools and workplaces with the ability to test on a frequent basis through this pooling type of surveillance. And so really asking you all to look at that platform by platform to know how large the pools can be on Roche versus the Hologic platform versus the Abbott M2000 platform versus the Cepheid platform and all of the Thermo Fisher and BD platforms to really understand what is the pool size that can be utilized so we can greatly increase surveillance testing. Why is that important? Well, because the piece that we recognize now, and that was the second piece that was surprising to me, is the amount of asymptomatic cases. And so it's very difficult to do contact tracing when people don't have symptoms and you can't diagnose the index case. So you have to do much more what we call proactive surveillance testing, where you go into communities that had their first hospitalization and really expand testing all through that community to find the asymptomatic and mild cases that really, and I always make this very clear, no one is intentionally transmitting the virus. People don't know they're infected. We saw this with HIV. We see this with some other diseases like chlamydia and HIV. Silent transmission occurs and has to be informed by different methodology than waiting for people to develop symptoms and come forward. But because of the work that you did early on and now really switching to the role and the critical role you have played in testing, not only did you identify the issues for us to make it very clear and give me a view across the United States from small rural areas to more metropolitan areas, where were the problems so that we could respond. But also really making it clear within each of your hospitals how to link specific platforms to specific requirements. And I think that's going to be really important going forward. Where with certain platforms where you can continuously feed tests and get answers very quickly for emergency rooms versus those that can be done as batch testing because it's utilized more as a surveillance technique. Because of your ability and the increase in testing, we were able to diagnose individuals at the hospital level, which was very important for the nurses so that they could create COVID wards and really serve the needs of large numbers of populations coming to the hospitals, but also allowed us to really do compassionate use therapeutics. And you were at the forefront of really making it possible to make those diagnoses in the clinical areas so that people had access to different compassionate use therapeutics, from remdesivir and now plasma, all coming forward because people can be diagnosed and offered treatment early. And so this next evolution in testing, while we have people working on the next scientific breakthrough to dramatically increase our ability to do additional tests, there's things we can do now. We don't have to wait. And that gets into this question of pooling and how big the pools can be. Sometimes we want to wait for the perfect and new scientific breakthrough, but when you work in sub-Saharan Africa and resource-limited settings, you learn to be creative and innovative with what you have in order to serve more and have more outcomes for that specific test. And so as we go forward and as we move testing really out of the clinics and into the community where it really needs to be in order to stop the spread of this virus, you all are going to be absolutely key to that. It's going to take all of us out of our comfort zone. It's going to take us out past having limb systems that are hospital specific into limb systems that can be shared across the United States, from being able to just work within your hospital into to a broader community catchment that allows that interface on a daily basis between the community and the hospital. And I think this is going to be important for all of us to really reach beyond our traditional approach to medicine and testing and diagnosis, to get more and more engaged in the community. And I saw the 7,500 media and talks that were given, getting into the community and specific communities that we know to be of greater risk. And I think that's the third thing I wanted to leave you with. So the surprise that this epidemic is primarily in high and high middle income countries, to the surprise of how much of the spread is occurring through asymptomatic spread versus preclinical or symptomatic spread. And then the third really critical piece is how much it is pointed to our social disparities in health and access to health. And so when we look at the groups that have the highest hospitalization rates, it's among the poor. It's among those that have incomes less than $25,000. The actual highest proportion of hospitalization by ethnicity and race is among our Hispanic colleagues and our Hispanic Americans, and really figuring out how to translate your knowledge and your information about tests and science and how these tests work down to the communities so that the communities see the value in them proactively prior to symptoms coming forward and being tested, bringing forth your Spanish speakers so that they can have clarity on the science. I have always found that if the community is informed about the science and understands why it is important, the community will respond with that knowledge and really stop pandemics. We've seen it with TB, we've seen it with HIV, we've seen it with malaria, we see it with Ebola. An informed community is a protected community. And you're really at the vanguard of providing that kind of information out to the community levels, particularly when you're a trusted member of a laboratory in one of the hospital systems that is linked to those communities. And I really thank you for the work that you're going to do to help us really get tests to where they're needed. Because in my mind, it's never been about the exact number of tests. But do we have enough tests to really find the asymptomatics as well as diagnose those who are seen in our hospitals? Do we have enough tests to get into the communities at the first signal and do really comprehensive testing across that entire community? Do we have enough tests to make sure that those individuals who we know who are most vulnerable, who have multi-generational households, that when a member of that family who is an essential worker is out and working, that person can get regularly tested to protect their family member that is still sheltering at home because they have 3 or more of these comorbid conditions or they're over 80 years old. This is how we move forward, taking science to the community so that everyone understands how we can best protect one another by utilizing the information and the capacity that we have today. I know that there will be additional breakthroughs coming from you all and from scientists around the globe that will leapfrog us into additional testing. But while we have what we have, an expansion of the current platform, while we're doing 500,000 and potentially 750,000 tests a day, how do we expand that to the 2 million, the 3 million, and 4 million? And I guess I can say to you today, if we use our innovation, if we use this ability to pull samples, if we use our already current capacity, we have no excuses to not expand dramatically testing. There's a team working around the clock to make sure that you have swabs and transport media, because we know if we dramatically increase the number of tests per day, you will need those. Those are constantly being shipped out to states. But work with us and work with your research institutions and the platforms we have so that we go from 500 to 750,000 tests a day to the 2 and 3 million of tests a day. And then help us to make sure that those tests are available, because it doesn't help if those tests are sitting in your laboratories, but we don't have people coming forward to get tested. Help with getting the message out into the community by doing local news and going to virtual town halls and really getting the community to understand why regular testing and what we would call surveillance testing rather than strictly diagnostic testing, why that's important to really be able to protect those most at risk for this COVID-19. You have been beside me the entire way. Those of you who know my background know that I came up through the bench doing research in HIV and RNA viruses, creating tests for them early on in the military when we didn't have any testing for HIV. Now we realize, and this is the final thought I'm going to leave you with, to even put more pressure on you all. When we look at where the early signals are coming from, so I've been working with states and county data nonstop, day by day, integrating clinical data, epidemiologic data, and laboratory data. And I'm pretty confident at this point that I can say to all of you, the first indicator that I see that there's an inflection point when testing levels are high is the earliest sense that increased cases are coming is an uptick in test positive. And I think that is extraordinary that we're at that point now. And that is at the county level. So we can see down through the states into the counties right now, out of about the 3,100 counties in the United States, we have about 100 to 110 where the number of cases and test positive rates are going up. I believe that that is our first signal. It's a signal before cases coming to the hospital. It's a signal before syndromic cases. It's a signal before influenza-like illness. And that early signal is dependent on you all. And you all both increasing the testing in your communities, because it's not going to work as a signal if we're not keeping expanding tests into the communities so we can see those inflection points early. But that signal is so critical to us. And it's why we ask for daily reporting, which I know is difficult for everyone to really be doing that. But it is really critical for us because we could see Texas and Alabama and the cases in the South starting to increase. And we could then alert the governors about expanding testing into those specific counties. So right now in Texas, yes, their cases are rising and their test positivity is rising. But if you just look at the map, it looks like Texas. But in reality, it's just 3 counties in Texas. And that allows us then to really focus like a laser on what needs to be done for those 3 counties, for expanding testing in those 3 counties. This is what we can do together with the information we have now. I have always called it the tyranny of averages. I don't like when cases are summed up in the United States, because if you look at it, sometimes they say, why don't we look like Europe? Well, I can tell you exactly which states look like Europe. New York and New Jersey looked exactly like Europe. Massachusetts flattened their curve more than New York and New Jersey. So did Pennsylvania, so did Louisiana, so did Illinois. But now when the virus has moved to a new state, they will also have a curve like Italy, or hopefully more flattened like Pennsylvania and Massachusetts. This is what we can do together. And we are United States. And so each state is different, each county is different, each experience is different. You are on the ground. You're our eyes and our ears through your very laboratory testing. And if we all work together to expand that capacity to get testing into the right age groups, I just got a report from the governors today that the average age of the test positives in one of the states has gone from 65 in March and April to 50 in May to now 35. That tells me that we're getting the information out there that everybody should be tested. You should not wait for symptoms to be tested. And I really want to thank you all for being part of that communication. And really thank you to Stefano and to the laboratory directors. You were well represented. They got on the phone and they really were very clear where the issues were. And that was so helpful to me to hear that and to hear from each of the lab directors about where the problems were so that we could solve them. Just know that I am only a phone call or email away, and it's only through on-the-ground experiences that we get to see what is absolutely needed, county by county, community by community, state by state, so that together we can control this pandemic. I know with your help and your continued expansion of testing, we will be able to get there together. Again, thank you to the entire society. You are a voice that I trust and listen to, and I just want to thank you for the work that you have done and really challenge you to help me with the platforms we have today to dramatically expand testing through pooling and doing pools in the community with outreach workers, that as soon as you see a case, you're going into that zip code and helping to test all the households and individuals in that community through meeting the community where they are with their needs. And remember, as you are doing virtually today, social distance, wear masks when you can't social distance, and continue to support one another so that together we can control this pandemic. Thank you so much.
Thank you, Dr. Birx. This was truly remarkable, and thank you for your kindness. Looks like you tasked us with some significant more work, but we are ready. We stand here to support all our governments, our counties, and this is all through that amazing, super trained laboratorians that are really the backbone, they've been the backbone of this crisis on the testing side. And in the absence of therapeutics or while developing or prevention of vaccines, diagnostic has been the front line. And so I think your words are very encouraging to all of them. And we heard loud and clear your cogent analysis, what is needed next. We're ready. I'll call you tonight, and we'll get to work to that. So really, thank you so much, and keep up the great work on behalf of all the microbiologists. Thank you.
Thank you. And
now we should have Dr. Hotez joining us here on our virtual stage. They're sort of a teleporting from the room into the virtual stage. It is really my very distinguished pleasure to introduce Dr. Peter Hotez, who has joined now on the virtual ASM Microbe stage. Dr. Peter Hotez is a professor of pediatrics and molecular virology at Baylor College of Medicine, where he's also the founding dean of the National School of Tropical Medicine and the co-director of the Texas Children Center for Vaccine Development. Dr. Hotez leads efforts to develop global health vaccine for poverty-related neglected disease, including schistosomatosis, hookworm, Chagas, coronavirus infections, while establishing a global network for neglected tropical diseases that provide access to essential medicines and innovations for more than 1 billion people in the low to middle income countries such as Africa, Asia, and Latin America. Dr. Hotez in 2015 and 2016 served as U.S. envoy for the U.S. government, building vaccine diplomacy initiative in the world's Muslim majority countries. As you can tell in this opening session, we tapped heavily the Department of State for our opening speakers. Dr. Hotez is an elected member of the National Academy of Medicine and the American Academy of Arts and Sciences, and also the Academy of the American Academy of Microbiology. He is the author of more than 500 scientific papers and 4 single-authored books, notably one published by ASM Press. And actually, there's a book forthcoming by the end of the year. We really commend Dr. Hotez for his highly active role in working to shape a national response to the growing anti-vaccine and anti-science movement, something that is greatly concerning to everyone and to ASM in particular. Dr. Hotez's presentation today is titled Preventing the Next Pandemic, Vaccine Diplomacy in an Age of Anti-Science. And this is also the title of his forthcoming book, I believe. So, Peter, we are really delighted that the ASM Microbe attendee will get a sneak preview, but we'll still buy the book. So, Dr. Hotez, as always, it's such a great pleasure to have you with us, a longstanding ASM member, and I'm sure all ASM Microbe attendees look forward to your presentation. Thank you very much.
Well, thank you. Thank you very much, Dr. Bertuzzi. It's really an honor to be at this fantastic session hosted by ASM, and a particular honor for me to be able to follow on from Dr. Birx, and I've admired her work for many years. So this is very special for me, and thank you so much. I'm going to share my screen, and I'm always amazed when things actually work. And I hope it's all working. And hopefully everyone can hear me, and that's working well. So that's right. This is the title of my next book that I expect will come out from Johns Hopkins University Press this time at the end of the year, beginning of next year, Preventing the Next Pandemic, Vaccine Diplomacy in a Time of Anti-Science. And hopefully I'll explain what that means. And the way this goes is we've been making extraordinary progress in the prevention of vaccine-preventable diseases. But my premise is that we've hit a snag over the last 5 years, and our gains are not as rapid, and in some cases actually slowing or reversing. This is where we've been at over the last, since 2000, since the launch of the Millennium Development Goals, when there was one around child mortality to expand the number of kids getting vaccinated globally. And this is when the Gates Foundation started, and their first large grant was for the Gavi Alliance, the Global Alliance for Vaccines and Immunizations, with $750 million. And this has been extraordinarily effective. We've seen dramatic declines in the number of kids dying from measles, pertussis, tetanus, Haemophilus influenza, type B, and diphtheria. These pictures on the right are actually from Sebastião Salgado, a fantastic photographer from Brazil who spent considerable time going around the world photographing kids getting their vaccinations. It's a very moving set of images. And my own experience on vaccines goes something like this. I was a pediatric house officer in the 80s in Boston at Massachusetts General Hospital and the Children's Service there, and I was admitting a kid every couple of weeks with Haemophilus influenza type B meningitis. And back then they had microscopes in the Mass General emergency room, and the expectation was the house officer would do the lumbar puncture, you'd look at the cerebral spinal fluid under the microscope, do the Gram stain, and your heart sank when you saw polymorphonuclear leukocytes and gram-negative organisms, because you knew there was a high likelihood this child might suffer from permanent neurologic injury. And then a miracle occurred, and the miracle was we had a series of vaccines that came online, but it was really the work of John Robbins and Rachel Schneerson, who figured out they needed to haptenize the polyribophosphate capsule onto protein to make it a better, more immunogenic vaccine for infants. And then the disease disappeared. So this was a disease that I went from admitting a kid every couple of weeks on my service to something that completely disappeared, so that by the time I was in pediatric infectious disease attending at Yale, I taught about it purely for historic interest. And it really cemented for me the power of vaccines. I also like showing this slide because it points out something that I think is going to be relevant to COVID-19, and that is the first vaccine is not always our best vaccine, that they go through a series of improvements. And this is not only true for Hib, it's also true, of course, for HPV, for cervical cancer and other cancers. It's true of rotavirus. It's true of many vaccines that we have, that the first gets replaced. It's almost as if the first one has a built-in obsolescence. And I remind people of that when people talk about the race for the COVID-19 vaccine. I say, be careful what you wish for, because history says that whatever comes out first or second may likely be replaced in subsequent years. One of the premises of my books is that despite these gains, we've now hit a bit of a snag, and we're starting to see these hotspot areas appear where disease is returning, both neglected tropical diseases and vaccine-preventable diseases. And they're in far-flung places from Central Latin America to parts of Africa, the Arabian Peninsula. And one of my observations is that it's where there's this constellation of social determinants together with climate change. It's where political instability or even outright conflict is combining with climate change, urbanization, deforestation, or anti-science. And I think one of the messages for today is, as microbiologists, as scientists, as biomedical scientists, we often don't get training in all the things I've listed here: political instability, climate change, urbanization, deforestation, or anti-science. And one of the messages of the book is maybe we need to think about that. And then I take the reader through a series of case studies, for instance, on the Arabian Peninsula, where there's been a dramatic resurgence of cutaneous leishmaniasis in Syria and Iraq due to the collapse of the health systems there, and also vaccine-preventable diseases such as measles, or the rise of cholera in Yemen, all because of this perfect storm of forces, which includes climate change, where the temperatures have risen more than 50 degrees Celsius, causing people to flee ancient agricultural lands, pour into cities, and that destabilization itself is additive. Similarly, in Venezuela, with the collapse of the Maduro regime and socioeconomic declines, this has interrupted health systems, brought back measles to Latin America, and that's a measles map at the top there, and you can see it. Looks like it's literally dripping from Venezuela into the Amazon state of Brazil and into Colombia, where it's affecting indigenous people such as Yanomami, the Yanomami people on the Venezuela-Brazil border, or the Wayu indigenous people on the Colombia side of Venezuela, and really decimating populations there. And then, because there's been limited employment, people are resorting to working in the mines, and they're often called the malaria mines, because in populations that historically have never been exposed to malaria are now sleeping outside, and there's been a 400 increase in malaria. So again, it's these forces at the top that are working together to causing these dramatic declines. And then we're seeing this in sub-Saharan Africa. Jeffrey Gettleman from the New York Times has coined this term, the Africa Unwars, to remark on the fact that it's not simply between warring factions, but in fact armed banditry upon civilian populations in the Boko Haram areas of northern Nigeria or Democratic Republic of Congo. Again, all of these forces listed above are combining, and many are surprised that I would put Texas and the Gulf Coast in that same category, but indeed we are seeing now the combined effects of climate change and urbanization bringing back vector-borne diseases. And I head our National School of Tropical Medicine at Baylor College of Medicine, where our faculty and scientists are looking at the rise of Chagas disease and mosquito-borne infections such as dengue and Zika and chikungunya. But my argument is a constellation of forces it's my belief and premise of the global South, Africa, Asia, and Latin America. But on a numbers basis, they're overwhelmingly in the G20 countries. But it's the poor living among the wealthy, or as they sometimes call the poorest of the rich. And I give it a new name to distinguish it from traditional norms of global health, developed versus developing country, to say that it's really the bottom segment of society living in the G20 countries that account for disease, and coined this term blue marble health to report on it. And I think a good example is what we're seeing now with COVID-19. So the book on the lower right came out in 2016, and now I've done a COVID-19 instant book update, which you can download free from Project Muse at Johns Hopkins University Press. This just came out. And if you look at the 9 to 10 million cases of COVID-19 globally, they're overwhelmingly in the G20 countries, but it has been the poor among the wealthy that are disproportionately being affected and suffering from, not only because of high rates of comorbidities, but living in poor, low-income neighborhoods has exposed individuals to higher rates of disease, as Dr. Birx has pointed out. And we're seeing this here in Texas now, where unfortunately we're seeing now a very steep rise in the number of cases of Texas. This is new data from our 7-day rolling averages, and you can see that vertical slope coming up for Houston and Harris County. And then below are the policy lab models coming out of the University of Pennsylvania, looking almost apocalyptic. And right now, Houston is getting hit the hardest in a state that's getting hit very hard. That little meter, that colored meter that you see on the bottom there, is our ICU beds. We're part of the Texas Medical Center, which is the world's largest medical center. We have 2,600 ICU beds in the TMC, and they're only about half full, but the number's going up pretty quickly. And on the left, Harris County and Houston has looked at the demographics, and we're seeing very high death rates among African American and Hispanic populations. So again, very much this blue marble health concept. And there are many different approaches being taken. We're committed to developing vaccines. I head the Texas Children's Center for Vaccine Development. This is a slide that Dr. Fauci showed a couple of weeks back at the National Academies, looking at the different platforms. And I like to make the point that the approach actually is quite similar, despite the differences in technologies, whether it's a recombinant protein vaccine like ours at Baylor, or a particle vaccine, or a DNA or RNA vaccine, or a live attenuated vaccine, or an adenovirus vectored vaccine. It's all about inducing a strong immune response against the spike protein. We showed over a decade working on SARS and MERS that it was all about inducing high levels of neutralizing antibody against the spike protein. That was the best determinant for protection. And now Dan Baruch's group at Harvard and Beth Israel Deaconess has showed something similar for SARS-CoV-2 in non-human primates. So inducing high levels of neutralizing antibodies is not the only thing needed, but it's certainly an important area. Now, what we're doing, because we're not a company and can't benefit from the Operation Warp Speed, is we're focusing most of our attention, because we do global health vaccines, on a global health coronavirus vaccine. And for that purpose, our Texas Children's Center for Vaccine Development has now struck up a partnership with PATH, which is Seattle-based. They've historically done a lot of work with the Gates Foundation. They led the development of the meningococcal A vaccine for Africa and the malaria vaccine for Africa. Now we're partnering with them. And on the bottom, there are groups that we've been working with, either currently or in the past, on this, and particularly the New York Blood Center, which did a lot of the important groundwork for coronavirus vaccines, headed by Shibu Jiang and Lan Yingdu, and then manufacturing with Walter Reed Army Institute of Research and supported by the National Institutes of Health. And this is our portfolio of vaccines in our Texas Children's Center for Vaccine Development. We develop low-cost recombinant protein vaccines, typically through microbial fermentation, particularly yeast or bacteria. And we actually effect technology transfer to low and middle income countries. And on the left, there's my co-partner for 20 years in science, Dr. Marielena Bertuzzi, who's the co-director of the Texas Children's Center for Vaccine Development. And you can see on the right that we're mostly focused on developing vaccines for parasitic infections such as schistosomiasis and river blindness, leishmaniasis, and Chagas disease. But we got linked to the New York Blood Center through a colleague, Sarah Lustigman, a decade ago, and thought that coronaviruses were going to be here to stay. And we partnered with them to begin, even though we're not virologists, to begin this coronavirus vaccine program. And the need for a low-cost vaccine produced by microbial fermentation is pretty clear to us, as this virus is now decimating the crowded favelas of Manaus and Belém and Fortaleza, and then in Guayaquil in Ecuador. And now we're starting to see in the crowded urban areas in Delhi and elsewhere in India, in Dhaka and Bangladesh, and then sub-Saharan Africa. I do believe this is going to be a catastrophic situation that we'll start to see soon in South Asia as we proceed through the summer months in the global south and in sub-Saharan Africa. And the problem is simply waiting for the technologies like the Moderna mRNA vaccine or the DNA vaccines or adenovirus vaccines to filter down to low and middle income countries. I don't see that happening soon. So we're now specifically looking at developing our Pichia-based recombinant protein vaccine initially for India, and we'll hopefully announce more details for that in the next week or two, and then globally. And what we've been doing, just like our other global health vaccines, is the nice thing about the Pichia pastoris platform is it's used, or related yeast, including Hensanula and some others, is used to develop recombinant protein hepatitis B vaccine that's made locally in Bangladesh, in Brazil, in Cuba, in India, and Indonesia. So we can build into that right away. And initially, we've had two different approaches. One is from our previous work supported by the NIH, we had developed a recombinant protein vaccine in Pichia for SARS-1, the original SARS back in 2003, and it was shovel ready to go in terms if we can demonstrate heterologous protection against COVID-19. But in parallel, our group, once we had the full sequence of the virus, we were able to move quickly starting in January to develop the second receptor binding domain for the S protein. And this is our SARS-CoV-2 RBD. And these are our different timelines, and we're developing both in parallel. And one of the reasons that we focused on the receptor binding domain is for a few reasons. One, we can induce high titers of neutralizing antibody. Our colleagues, Shibu Jiang and Lan Ying Du, had shown that the receptor binding domain allowed the removal of certain epitopes that were in the full-length spike protein that was causing eosinophilic immunopathology, or what's sometimes referred to as immune enhancement. And this is a similarity between SARS-1 and SARS-2. So starting in January, we resumed our work on the SARS-1 while aggressively moving to make SARS-2. And we're finding quite a bit of structural similarity. And the really interesting thing that we're finding in terms of producing our SARS-2 molecules, everything we learned from SARS-1 has directly been applied for SARS-2, and I'll explain that in a minute. This is our original data on the SARS-1 receptor binding domain. We could produce lots of it, high yield in Pichia pastoris. And one of the things that we do in our approach, since we can't afford a lot of expenditures for patents, what we do is we put everything in the public domain. I will publish every step of our studies so nobody else can block it. It's kind of an interesting strategy to take, but it's one out of necessity since we don't have hundreds of $1,000s for patent costs, or if we did, I'd rather use it to recruit scientists rather than pay for patents. And this is our very high titers of neutralizing antibody that we can achieve both against pseudovirus as well as live virus. And again, we find that's an absolute essential requirement, and we get 100% survival as opposed to the high death rates in our laboratory control animals. So this has been a very successful vaccine program. And then we can show also that we can minimize immune enhancement. And so people hear a lot about the eosinophilic pathology or immune enhancement, but not many people actually get to see what this looks like. And we've been doing this for years. So for instance, these brown dots are immune histochemistry staining for eosinophils. And this is what you see if you use the full spike protein using different adjuvants. So we see both with the inactivated virus as well as the spike protein, quite a bit of eosinophilic immune enhancement. These are studies done by Ken Chang at the Galveston National Laboratory, our collaborator. Whereas if we go to the receptor binding domain, we can, especially depending on the right formulation, we can minimize this. So we can actually control for when we do see or don't see eosinophilic immune enhancement. And now Lanning-Du has been able to show that our antiserum to the SARS-1 cross-reacts with the SARS-2 RBD, as well as neutralizing pseudovirus as well. So we're moving forward with that. But what was really interesting is I didn't think we could move that quickly on the SARS-2, but basically our scientists in our group at the Texas Children's Center for Vaccine Development, people like Wen Chen and Yoram Pollitt, and a group of about 10 scientists really work day and night to see if we can make the same expression strategy work for our SARS-2 RBD. And here's an example. So for instance, with the SARS-1, one of the problems that we had was extensive glycosylation in the yeast system, in the Pichia pastoris system. And Bin John and our group had found if you remove the N-terminal express it without the N-terminal amino acid, you can greatly reduce monoglycosylation. And this turned out to be true for SARS-2. So the smear that you see here is with that N-terminal amino acid, but you can get a nice tight band for if you remove that N-terminal amino acid. Now you might say, well, who cares? Is it really affecting immunogenicity? Doesn't seem to that much, but the problem is if you're trying to scale this up, trying to manage and figuring out how to control a smear is really a problem. So this makes production much easier. And now we're getting the serum tightly binding and interfering with the ACE2 receptor. So we're moving pretty aggressively on this and now transferring the technology to India to hope that we can have now a vaccine for India for our receptor binding domain, inducing high titers of neutralizing antibody. And the possibility now we're also looking to see if we can expand our U.S. strategy to do the same, even though it may not necessarily be a component of Operation Warp Speed and have the benefit of the BARDA support for scale-up manufacture. We're hoping this may come down later in potentially Operation Warp Speed Volume 2 or 2.0. Now, having said that, I do want to express some concerns about the approach. There are a couple of things that Operation Warp Speed's doing that I think does require an earlier mid-course correction. First of all is the term Operation Warp Speed. I really hate that term. And the reason I hate it is because, I've been, as many know, I've been fighting the anti-vaccine aggression and lobby for much of my scientific career. I'm both a vaccine scientist and a pediatric scientist, but I'm also the parent of an adult daughter with autism. And the things that the anti-vaccine lobby claims is they claim we're rushing vaccine. They claim vaccines cause autism, which I've spent a lot of time debunking, and I can talk more about that. But also they claim that we rush vaccines, we don't adequately test them for safety, and there's this conspiratorial alliance between the pharma companies and the government. And the messaging that's been coming out of Warp Speed, as well as the some of the behavior of the biotechs and their press releases saying they're going to have vaccine in days or weeks, which they won't, or the concerns about the conflicts of interest and the stock dumping and all those kinds of things. there's a tone deafness and lack of recognition to the fact that this is enabling the anti-vaccine movement. So both Reuters and the Associated Press with NORC have done 2 polls. They're showing that up to half of Americans will not accept COVID-19 vaccines, even if they're made available. And I feel that this is partly a self-inflicted wound that could have been avoided. This is, it's particularly aggressive here in Texas, where we work. This is the rise in the number of kids who are denied vaccines by parents who deliberately opt them out because they feel vaccines are unsafe. And we're now seeing this very accelerated rise. We haven't got the new numbers yet, but we're moving upwards towards 100,000 kids not getting vaccinated. And this doesn't account for any of the 300,000 homeschooled kids. And it's particularly bad in the Austin area. And what we're seeing now is under this fake term that's being thrown around Texas by the Texas Freedom Caucus and others, health freedom, which I don't even know what that means. What we're seeing now is the anti-vaccine people are expanding their remit and now campaigning against social distancing, contact tracing. It really is very much an anti-science movement. And you can see some of the names they're targeting. And unfortunately, I'm on the list as well. This is the kind of examples of what we're dealing with. This is a sitting member of the Texas legislature who says bought and paid for by the biggest special interest in politics. And of course, we don't have any support from the vaccine manufacturers, and yet this is thrown around, and again under this guise of health freedom. The Houston Chronicle recently published a political cartoon with this sort of disagreement that we're having with this member of the Texas legislature. It's a fun cartoon. They made me a little portlier than I like to think of myself, but you get the idea. And I'm quite worried. I'm worried that this is growing. We've already now this year, for somewhat different reasons, have seen steep declines in the number of kids getting their childhood vaccinations. When we implemented the emergency order, this is from the Centers for Disease Control and the MMWR, we saw a steep decline because parents weren't bringing their kids into the pediatrician. Now we're starting to see some rebound, but the older kids are still not getting vaccinated. And I'm worried that this anti-science, anti-vaccine movement that I'm seeing growing will prevent that upswing. So I'm worried that we're going to see now not only continued COVID-19, especially in the South and Texas and Florida and Arizona, but we're going to see now potentially the return of measles, and return of influenza. And we're seeing more and more scenes like this where those protesting social distancing and contact tracing are also aligned with the anti-vaccine people. And now they're starting to walk around in camouflage and guns and they are going after scientists. So my new name given to me by RFK Jr. is the OG villain. I am the original gangster villain. So today you're listening and ASM is hosting the original gangster villain. And doing what we can as academics. This is the book that I've written back recently, Vaccines Do Not Cause Rachel's Autism. And that's my daughter, Rachel there, my youngest daughter, who's got autism, a number of intellectual disabilities. And we talk about the whole exome sequencing that we did, and my wife and I and Rachel, because now the Broad Institute at Harvard MIT has identified more than 100 genes, including a quarter that are involved in neuronal cytoskeleton. And Rachel has a neuronal cytoskeleton, a mutation in one of the non-red cell neuronal spectrin genes. So it very much goes along with that. The point being that not only is there massive evidence showing there's no link between vaccines and autism, but there's no plausibility, because we know now autism begins in early fetal brain development associated with those genes. And just as we were starting to have some success sort of knocking that down, it's sort of like whack-a-mole. Now all of the stuff, because of what's been happening with Operation Warp Speed in the biotech, is now driving down vaccination rates. The other thing I'm quite worried about is this unnecessary level of nationalism we're appending to vaccines. We're hearing about the Chinese vaccine or the American vaccine or the British vaccine or the European vaccine. And I feel strongly this has no place when we're talking about trying to solve a major pandemic. In fact, there's even a new name for it that you can see on social media called vaccinationalism. And I feel it has no place in modern science. And I remind people that when Albert Sabin on the left developed the oral polio vaccine, he did it jointly with Soviet scientists at the height of the Cold War. Sabin traveled with his oral polio strains, went to the USSR, and scaled them up in the USSR. That's where it was actually made and tested on 10 million Soviet school children. Those trials were certified by Dorothy Horstman, a Yale epidemiologist, one of the first professors, women professors at Yale School of Medicine, who was one of my mentors. And this is what led to the licensure helped to lead to the licensure of the polio vaccine. And when I served as U.S. science envoy in the Obama administration, I very much wanted to see if we could pursue this. So we began working with Muslim majority countries for joint vaccine development in Malaysia and across the Middle East. And this, at that time, was focused more on our neglected disease vaccines. We have 2 vaccines now in clinical trials for hookworm and schistosomiasis. This is one of the components that we're particularly worried about is this condition, female genital schistosomiasis. This is from the New England Journal paper we had last year. It affects 40 million girls and women. It's a cause of pain, bleeding, stigma, depression. Adolescent girls are falsely accused of promiscuity by community health workers, and not because they don't realize this is not sexually acquired. It's acquired by standing in bodies of water where they're attacked by where the water is contaminated by the infective larvae of schistosomes. And now it's been linked to a 2 to 3-fold increase in acquiring HIV/AIDS. So in collaboration with groups at GW and George Washington University, James Cook University, and Fiocruz in Brazil, we were able to identify very promising surface protein that's giving good levels of protective antibody. And this was done in association with the Vaccine Trial Evaluation Unit supported by NIH with Baylor College of Medicine. And we're getting good antibody titers. And I show this slide not because it's amazing antibody titers, but the fact that adjuvant access is a big issue for us. Those of you who've ever taken the Shingrix vaccine will remember it hurt quite a bit. And the reason it hurt quite a bit is because it's a recombinant protein that's formulated with monophospholipid A and QS21 in GSK's adjuvant system formulation. It's a great adjuvant, but we don't have access to it. So we have to rely on open access adjuvants. So we're getting strong protection, but this is always a problem for us as adjuvant access. We have a hookworm vaccine that also targets the blood-feeding apparatus of the hookworms. This is a picture of Catherine Jones, and our group has been leading the development of a Chagas vaccine that blocks fibrosis that can accompany Chagas disease, even in the presence of chemotherapy. In this case, we've been doing a lot of work with ASI, who's given us access to their E6020 adjuvant, getting a lot of success at blocking all of the fibrosis. Then we're interested very much in cutaneous leishmaniasis vaccine, the locals call Lepo-Evil, because it's so disfiguring, causing permanent scars. And now we have this wonderful collaboration with Jesus Valenzuela and Shan Kamhawi's group. It's National Institute of Allergy and Infectious Disease, together with Naomi Aronson's group at Uniform Services, looking at a bivalent vaccine where we can target both the parasite and the sandfly at the same time. And we're hoping to move that one as well. So it's late. I'll finish and just say, the future we see very much as an epic struggle, and the epic struggle goes something like this. We are making progress at developing vaccines, but I'm very concerned about all of these 21st century forces that we're seeing, this shifting poverty and climate change and war and political collapse, urbanization, and now this rise in the anti-science. So I'll stop there. Dr. Bertuzzi, I know we went a little bit over today, and I'll be in your hands in terms of how you want to proceed with the Q&A, if that's how you'd like to proceed.
Excellent. Thank you so much, Dr. Hotez. This is a fantastic overview going through the science, the national and global level, and of the enterprise and the advocacy that is needed in this space as we prepare for the COVID-19 vaccine. So thank you very much. And these were two fantastic presentations. I'll turn it over to Jonathan Stevens Garcia, who is ASM Chief Operating Officer, who has been taking scrupulous notes on the questions that were coming through for our speakers, Ambassador Birx and Peter Hotez. And so, Jonathan, what have you heard?
Thank you, Stefano. Well, I've heard a lot of questions, and a lot of them, of course, focused on COVID-19. So what I'd like to do is begin with a couple of those while we have the valuable time of Ambassador Birx, as well as open them up to anyone else on the panel. So I got a couple of questions along the same line, and I've tried to coerce them into one question, and that's about borders. Microbes know no borders. However, the inequity of the impact of the pandemic is highly dependent on the quote-unquote borders of the inequities that exist in counties, in states, and countries. What can we do to address this barrier in the prevention, testing, and treatment of COVID-19?
That's a really critical question, and it's one that I worry about every day, having come out of a field that was highly stigmatizing, and people were very highly vulnerable, from our LGBT community to young women in sub-Saharan Africa. And I think it really gets to who is really vulnerable to this disease. And I am often struck by the people who say, you know, Americans were following the stay-at-home order. Yeah, 50% of Americans were still working. All of our essential workers were still working. All of the people who needed the income and were providing our healthcare, our food, our truckers, our mailmen, they were all still working. All exposed, being out in the workforce every day. And I think when I talked about the highest vulnerability for hospitalization, the under $25,000 a year income, it's really absolutely critical. So for all the therapeutics, so what are we doing about it? First, we're making sure that we've moved testing into vulnerable neighborhoods through our federally funded clinics. And HRSA has been an incredible partner in this to really get testing inside, but also working with the agricultural workers and other workers that are particularly cohabitating in large groups and eating together, to really make sure that we're getting testing into those groups. And finally, to make sure that therapeutics, we all know that there are hospitals more able to pay. And sometimes within the United States, hospitals that have less ability to pay are often offered less treatment. So really making sure that these innovative therapies, the remdesivir, the reason I've been scrupulous about matching hospitals and remdesivir is because I'm very worried about public hospitals and other hospitals that may not have quite the same ability to pay. And the same way with convalescent plasma. It's on all of us that are working in laboratories and in the front lines and in communities to really be working with community leaders to make sure that what we think is happening on the ground by the data is actually happening on the ground, and really getting ground truth to make sure that our testing and our therapies are available across these community borders and really is serving the needs of all people in the United States of America.
Thank you, Ambassador Birx. If I may, one more question that talks about the international aspects of COVID. The speakers have all highlighted the work and how important it is with our international colleagues. Now, the U.S. is talking about pulling out of some international organizations. So how can the ASM community advocate for continued support of international organizations based on the science and the exchange of information?
Well, I think we have to separate two pieces. The United States is highly invested in the Global Fund to fight HIV, TB, and malaria, and just had a sentinel increase in their contribution to Gavi. So I think it has to do with accountability and impact. And I think these discussions that we have been having about some of the other multilateral, multinational organizations has been around accountability in times of crisis. The issues that we have had transcend this current pandemic through multiple pandemics. And I think really is an indication for us that reforms have to continue to move forward. But as far as an investment, the American people should be really proud that the United States stands still as the largest bilateral donor in global health around the world, and also the largest donor for the Global Fund and for Gavi. And I think really proud to be an American and part of that investment that recognizes that we are part of a global community and we need to support each other in that global way.
Terrific.
Yeah, and I'll just add, Dr. Birx has been a true champion of global health and still is very much, and has done a lot to foster international cooperation and has my admiration for that. I am concerned about what's coming out of the White House in terms of language about the World Health Organization and now the Pan American Health Organization. I'm very worried. There's some reports that the U.S. may pull out their support for the Pan American Health Organization, which would be lights out for that organization. So I would just say it's just to reaffirm the importance of maintaining a strong World Health Organization and PAHO, because who else is going to fight this epidemic as it races through Brazil and Ecuador, or it goes through Asia? This is a time when we need the WHO and PAHO now more than ever.
So we often think of diseases forcing scientific advancement. And Dr. Grace Burke in the chat talks about telling her students there was R&D before HIV and there was R&D after HIV, signaling in a sense the growth in tools and knowledge gained in the fight against HIV, and those tools that we still use today. This is for Dr. Birx and everyone on the panel, but what are some of the things we are now learning with COVID-19 that we will carry forward to help us combat other diseases in the future?
I'll start. I'll be really brief. And I really so appreciative for that question, because sometimes the breakthroughs that we had in HIV aren't recognized. And certainly the laboratory capacity that's been built around the globe, but critically the immunologic. I mean, I trained as a clinical immunologist. The immunologic breakthroughs that are now translated into cancer and other therapy came out of really having to understand how the HIV commands the immune system through its impact on CD4 cells. And I think coming out of this, we'll have a much better sense of lung injury and the importance of different modalities and the viral impact on trying to understand that cytokine storm. Who has it, why they get it. I really appreciate Peter talking about genetics potentially in autism. There is something underlying this virus in certain individuals that have this cardiovascular, this clotting disorder, the lung injuries that transcend viral replication. I think those kinds of tissue impact of cytokines will be explored and understood beyond shock, when we used to study shock and bacterial infections and its impact. I think it will be and continues to be a real stress on our understanding. It did take me back, for those of you who worked in HIV, it was a little bit like post-traumatic stress disorder, because here you're confronted with a virus, hard to diagnose originally, not enough tests, and then not enough therapeutics. And you feel like you're stuck in that time warp. But what took us a decade before with HIV took us a matter of months. And I think that parallel should be drawn, that really the work that we did together in HIV to expand science and research put us in a position to go from multi-years of discovery into weeks of discovery. And it's great to be alive to have actually seen that happen. You hope that you don't hope that you ever have a pandemic, but you do hope that the knowledge that you've gained over a few decades can help respond to one.
And if I may, that's an excellent point. If I may complement what you're saying, Dr. Birx, on the advocacy side, what I also saw happening in the HIV/AIDS history is how researchers embracing the advocacy community has transformed the relationship of the scientists with society. That is something that's very, very dear to me. And I'm concerned about it also for the arguments that Dr. Hotez just made. And so to me, that's why it's so important, even in the post-COVID world, to always think of scientists engaging with society, whatever the issues are, in a non-judgmental way, but really listening and engaging. I think that's a very important lesson that we learned from the HIV/AIDS story.
So get all of your laboratorians out there talking in the community about what these tests mean, what that means for transmission. Really, you can be at the forefront of that communication, because part of this anti-science comes from us not articulating science in ways communities can understand.
Exactly right. Thank you.
Yeah, and I would agree. I mean, I think if I have a paper out in PLOS that came out a few weeks ago saying that part of the rise of this anti-science movement is that Americans have not been hearing from scientists the last few years. And I think if there's ever any silver lining for COVID-19, and there aren't many, it's the fact that for the first time now, Americans are hearing from scientists on a regular basis, and hearing from Dr. Birx and Dr. Fauci and a number of us that are going on CNN, MSNBC, and Fox News, and I think that's been great because they're hearing from scientists relatively unfiltered, and that hasn't happened much in the past. And I think that may help quite a bit moving forward.
And as a side note, I got a couple of private messages asking me to give you thanks, Ambassador Birx, for citing and thanking clinical laboratory directors and working in partnership with them. I think they felt very appreciated that you called that out during your talk.
It's true.
I have one question I think I can fit in last for Dr. Hotez, and that's regarding a particular part of your presentation. This is for everyone, though. Regarding testing, the current method of presenting data as the number tested positive. But would the results be more meaningful if we presented data as a percentage of the total population? For example, the percentage tested, the percentage positive cases from total population of a state, a county, or even national. Will that give us a better rate of progress and the enormity of incidence of a particular disease?
Well, I've been really tracking this very closely, of course, in the U.S. and especially here in Texas. And, I think the way I look at this is there's not one single number you can look at to really understand what's going on. So for instance, I'll look at the rise in number of cases and, express some alarm with that. And then people will come back to me, well, how do you know there's not that's not just a consequence of testing? And I'll say, well, it's because our Texas Medical Center, which is the world's largest medical center and the Medical Center of Houston, is showing a sharp rise in the number of hospitalizations and ICU admissions. And have to look at multiple things. And I also think the syndromic surveillance is going to be very important. So I think there's not one single metric you can look at. That's point one. Point two is, again, everyone talks about testing and number of tests. And yes, that's important. But I bring it back to what is it you really want to know? What you want to know is if you're going back to work, you want to know that there's a system in place where your colleague in the next cubicle, or if you're working at a restaurant, does not have asymptomatic COVID, and therefore putting you at risk and the people who frequent that business at work. And so, do we have a testing system in place at the workplace? Do we have adequate numbers of contact tracers? What's the syndromic surveillance network looking like in our city that can identify clusters of cases of fever and respiratory illness? Do we have epidemiologic models for each major metropolitan area? So we have a roadmap to go on, and what's our level of public health communication? So, it's all, you hear testing constantly, and I understand that, but it goes beyond that. It's whether we have the whole health system in place in our major affected areas.
Dr. Bertuzzi, Dr. Patel, any comment?
I yield my time.
I will just comment that it's a time-dependent factor as well, right? So a person can be not infected today and infected tomorrow. And so how to incorporate that in a denominator is a complex question, right? And it means that if you're going to do extensive testing, you may be testing many people more than once because the situation next week is different than it was last week. So complicated, and we're learning as we go. I agree with Ambassador Birx that we really haven't done a lot of asymptomatic testing, maybe outside of HIV on the clinical side. But, now it appears with this particular virus that to understand where it's hiding, we need to know that answer. So it's really changing the way we deliver diagnostics. I'll also thank Ambassador Birx for bringing up the HIV analogy. I think that the diagnostics field really served that field well. Without the diagnostics we have for HIV, we could not be where we are today with HIV. And quite frankly, it's the same thing with SARS-CoV-2. If we didn't have the ways of testing that we have today and the excellent laboratorians to run those tests, we would not know what's going on. And it would be a very different world had this virus arrived, for example, back in the 1970s.
Well, thank you, everyone. Thank you for showing and giving your talks, but also for staying a little long to answer some questions. There was a lot of activity, and I know some of these got to some of the core questions of our audience. So with that, I'll turn it back over to Robin, who I believe closes our meeting today.
Great. Thank you, Jonathan. Thank you to our speakers today for their excellent presentations. Your presentations give us a lot to think about, and they also remind us, and thank you for doing this, how important our work is, especially during this pandemic. What a great way to start our Summer of Science. I'm looking forward to the rest of the sessions this summer. Please mark your calendars for the President's Forum, which will be held on Thursday, July 16th from 1 to 2:30 Eastern Standard Time. I'm excited to announce that Dr. Karen Bush, Professor of Practice and the Interim Director of the Biotechnology Program at Indiana University, and Dr. Paul Vervey, Professor of Clinical Mycology, Center of Expertise in Mycology at the Radboud University Nijmegen Medical Center, will be the guest speakers for this session, presenting on antibacterial and antifungal resistance. I hope to see you all then. Thank you for joining us today.